hello. It's Dr. Verdiales again on Tuesday evening to discuss some interesting cases that we've seen throughout the week. Hi Facebook, so I'm doing the dual thing. As usual, I like to start our talks with a dedicated subject. Today, I would like to discuss the cases that nobody wants. Okay, I will call them the taboo cases. As part of CNY Fertility, I am very extremely proud of the practice management, practic mode that Dr. Kills has adopted throughout his years at CNY, and that is we say no to no one. And then that allows us to do multiple things. One, be at the forefront of fertility care, because we're always getting the cases that other fertility clinics push away. So we're always being challenged to make it better for you guys. But also, we're here to serve. And it's really, really cool to see the underdog in their journey getting to that goal that they have set up, and that nobody is willing to walk with them. And so the subject for today was inspired by a wonderful lady I got to speak to today, and in her journey. And I would say that half of the consult was really to discuss the taboos, okay, the discrimination, the stereotypes out there of who should be reproducing and why. So I thought it was a great thing to talk about, because she felt very isolated in her journey and chastised. And when I was able to discuss with her, you are another of a CNY type of patient, she felt a lot of relief. And she actually mentioned that she felt validated, and that she was very grateful that I was able to discuss that with her, and that she felt that I was not going to judge her, and that it was okay to have that desire in her heart to be a mom, despite being criticized by friends, family, society, and everybody else. Okay, so thank you for those that are joining us now. I did start a few minutes early, so I apologize. For those of you who don't know me, I'm Dr. Verdiales. I am the Atlanta doctor. I always like starting this adventure by writing my name and how to find me. I know that some of you have been very frustrated with us lately. We are trying to improve patient flow, especially the phone calls. It's getting a little crazy these days, but we're working on being able to communicate. My email is usually easier, and I will make sure that it gets to the appropriate person. It's mverdiales@cnyfertility.com. I do have a Facebook page. Hello everybody, hello. I do have a Facebook page for the patients, so feel free to reach out that way as well. If you've never had a talk with me, you're welcome to reach out, give me your information, and I will give it to the staff so we can accommodate you to have a phone or physical consult. So going back to the subject of the day, the taboo cases, the cases that, society has determined that they should not be reproducing, and what can we do for them. So I'm going to start with the lady that I spoke to today. So she is 56 years old, and she had been to 2 fertility clinics. The first one actually turned her away, and then the second one helped her with getting donor sperm and donor eggs, and they made the embryos for her. But at the time that she was going to transfer, they actually started putting kind of, you need this, and you need medical clearance, and you need this and that. So she decided to kind of walk away from that and come with us and transfer her embryos to our clinic. And like I was saying, she felt pretty discriminated by her peers, her family, and even the doctors that she was seeing. And no one should tell you how to live your life, and nobody should crush your dreams. Dreams are like seeds, okay? They're seeds within us that, divine intervention or, inspiration of some kind has put in our hearts. It is our choice to put water on that seed and feed it and put it in good soil and let it bloom. And no one has the right to crush those seeds but you. I have read multiple articles on people that are in their deathbeds, and they don't regret, not having bought that car or not working harder or not getting more money. The things that they regret is, one, those dreams that they never pursued, that experience with a loved one that they decided not to, the petty fights with friends, family, and it's that, I should have gone after that dream of mine. I should have become an artist. I should have, done this or that. And it had nothing to do with material stuff. It was really, that journey that we have within us that we decided not to walk that path. So going back to my patient today, she was almost apologetic, and I was telling her, you don't need to be. You don't need to feel that way. Her particular situation is she had been a personal trainer all her life. So even though 56 is a number and she is beyond menopause, she was a very healthy 56-year-old. She is still a personal trainer and a bodybuilder. So, like I was saying, she probably had delayed childbearing. And as you all know, time can just keep rolling, and next thing you know, you're 35, and next thing you know, you're 40, and then you're 45. Time just rolls, things get in the way. And then one day you wake up and you realize that you had this dream that you never pursued. And in this particular scenario, it was to become a mother. She was also waiting for Mr. Right, and those, I'm sure some of you out there can relate. And Mr. Right didn't come. So she has 10 embryos actually that she's transferring, 5 that are PGT tested, and she's going to start working with us. So what do we do with our more mature moms? And that's one of the things I wanted to talk about. In general, if you're under 50, we don't, we don't ask anything additional in terms of your preconception testing and your ultrasounds and just the basic fertility stuff. Each case is different. So if you do have any health issues, we have multiple patients that are cardiac patients, diabetic, even with like tumors in the brain and all sorts of stuff. So we will need some type of clearance from the doctor that's handling those issues for you. And then if you're beyond 50, we do want a primary care clearance, and that probably will also have an evaluation from either primary care or cardiology, just to make sure that you're healthy enough to sustain a pregnancy. Is there an age limit to the patients that we accept? No, there is no age limit. You do have to be healthy enough to be able to carry a baby, And you have to understand that, there's a point where we will have to go straight into donor eggs. So if you are 50 and still having periods, the chances that we'll be using your eggs are pretty low. Okay, not impossible. I love the impossible, but it's going to be low. Um, so that's that on the age issue. How about single moms like her? I mean, I use her example as the age taboo. We don't really care. I mean, we're here to serve you, and and that's what we're here for. So that's one thing. What about known donors? We have no problems with known donors. The only issue is that they have to be tested. They have to become CNY patients, have to be tested. And you probably can get away with signing some waivers, because usually donor eggs and sperm get quarantined, or but we don't intervene with that. How about surrogacy? Actually, that's expanding. That is expanding tremendously. I know that there's some new laws that passed in New York State. I'm not that familiar with Georgia yet, believe it or not, even though I live here. But I know that those things, there are lawyers that specialize on reproductive, law. So we use surrogacy for gay couples. We use surrogacy for women that have lost a uterus. I had that question recently. She was not aware that she could still, become a mom and use her eggs, because she was fairly young and she had a hysterectomy for endometrial cancer, and she could still use her eggs. She just needed to get somebody to carry. And we have all sorts of different combinations of people. Another big taboo in some of the other clinics is BMI, or weight versus height. Okay? We say absolutely, come on in. I mean, there are a few things that we need to take into consideration in terms of anesthesia and stuff like that, but we will embrace you. I had a girl, she was one of my first CNY Georgia patients, and she was a beautiful young girl with severe PCOS, or she was like 31, and she had been turned away by 2 clinics because of her size. She had a BMI of about 48, which is considered morbidly obese. She had no health issues, just the PCOS, and she was on the heavier side. And they would not even prescribe her ovulation medication. They were like, you have to go lose weight, and then we'll get you pregnant. And she came in, we helped her, we put her on keto, we put her on the supplements, and she got pregnant on the 2nd month of letrozole and time intercourse. So that's another big taboo, size. Come on in, we love you. And then sexual orientation. We have all sorts of combinations of partners, and we will say no to no one. I mean, we have veterans, we have people that we have this one veteran, and he, they have to actually do testicular biopsies because he is paralyzed from the waist down. So those are some of the cases that we don't hear very often of, and they're as important as the more usual cases. And it's important for whoever's listening out there to let you know that your journey is as beautiful, as valid as everybody else's, and you should pursue it, and we're here for you. We are, I joke around with the patients, we're like the hippies of the fertility world, and I love it because that goes with my own way of thinking in life. Alrighty? Okay, well, that was, I wanted to touch that because I thought it was very interesting, especially that I was very touched today with that patient and the way she, she almost felt guilty that she wanted to be a mom in her 50s. So wherever you are, go girl. All right, so let's go through the questions. Let's see. Hi to everyone that I have had the joy of meeting by phone or in person. Okay, hi Stephanie. Very good. Okay, can you please talk about hydrosalpinx? Actually, I had that question today. I had a patient come in with a history of tubal ligation, and after her first retrieval, she developed a not a hydrosalpinx, but a hematosalpinx, meaning blood inside the stump of the tube. And we had that discussion today. To take out or not to take out is the question. I would take out. I would take out hydrosalpinx. I would take out, hepatosalpinx, and much more if there's any questions of infection, because those are, a sick tube serves nobody. In the case of that patient today that we had that discussion, she can't use the tubes. They're not serving her. They're segmented because she had a tubal ligation, and she already failed her first transfer. And I'm wondering if the tube had something to do with it. Can she transfer? Yes, she can, and that's what she has chosen to do. She decided that she was coming out of pocket for everything, and she did not want to jump into surgery, but that she was going to keep it in the back burner in case transfer number 2 failed. But if you're able to and you have the resources, I would take out those tubes, have a nice, fresh, clean pelvis, and jump into IVF. Not have that kind of gray cloud, kind of, is this going to be an issue? What if I fail 1 transfer? What if I fail 2 transfers? And then having to go back and take care of that. Do you suggest hysterosalpingogram or saline ultrasound? They're different monsters. I prefer the saline ultrasounds when I do them myself, because I'm able to actually have a full evaluation of your pelvis, and I would say 60 to 70% of the time I can actually check the tubes with a saline ultrasound. However, a saline ultrasound is not designed to check on the tubes. The hysterosalpingogram or the dye test is the gold standard to check on the tubes, to make sure that there's tubal patency and actually how thick and how big they are. However, the dye test is an X-ray, meaning it's a one-dimensional image, so you cannot really check the 3-dimensional structure, which is the uterus. With the saline ultrasound, we're able to really look through the entire cavity and the entire muscular layer, and then we get the bonus that I would say 60 to 70%. We can get a pretty good idea whether your tubes are open or not, or they're sick. Okay. Okay. So yes, we do not restrict. I'm answering an Instagram question. We do not restrict our patients by BMI, and the reason that we put people on keto is for fertility. It is for actually health. All right, a low carb diet, eliminating processed foods and any toxins. It's actually beneficial to the body. If the vessel, which is you, alrighty, it's in optimal health, then your uterus, it's all like a cascade of events. Uterus, the tubes, the pelvis, the ovaries, you're going to get better eggs. Even if it's a male, you get on a healthier, we are what we eat. You get on a healthier diet, you're going to have better sperm. The weight loss on keto, to me, it's a positive side effect. Does everybody lose weight on keto? No. Does keto have to be done for weight loss? No. There are people that don't need to lose weight or not interested in weight loss, and they can do keto and just increase the ratios of calories, and not lose any weight at all. But for those of you that want to shed a few pounds, it will be a nice side effect from you getting healthier. It is about a lifestyle change. It's not a diet, it's a lifestyle change. Okay? Very good. Hi, can AMH be falsely low a month after a miscarriage? Yes. My AMH was 0.89 in February, and had a miscarriage, and it dropped to 0.31. I wouldn't say it is false. Your body, okay, it's very dynamic. Even if we take your blood pressure and we check 15 minutes later, it's going to be a different number. Your heart rate varies. So your hormone levels vary, including your AMH. So I would not be too stressed about it. I would work on it. A miscarriage puts a lot of stress on the body and the endocrine system. So you can do some priming, you can get on the right supplements, do PRP, and I have seen those numbers bounce back up. Can a person ever do priming too long? No. If you look at all the different things that we use for priming, except for the human growth hormone, all of it can be done long term. And what I was describing before, it's about lifestyle change. So you are getting healthier, and hopefully you will do this forever, and it will be accumulative. The reason that we say to do priming 1 to 3 months is that usually by 3 months we start seeing, the first 2 months we see a pretty fast improvement, and then by the 3rd month we start seeing a little bit more of a plateau, okay? But not a plateau like flat, but just the improvement is more gentle. But you're still accumulating improvement for your overall health, and that's what it should be. So there's not such a thing as too much priming. Low dose naltrexone can be used long term, and actually there's a lot of research on it for chronic inflammatory diseases. Human growth hormone, that's the one that I would not recommend to be on long term. It makes me a little nervous when somebody is more than 3 months on it at a time, because there's not enough data, and as the name says, human growth hormone, growth, it will stimulate growth of things that we might not want to grow. So, short term, it's fine. Long term, makes me nervous. Okay. Adoption seems much easier. I agree, and that might be the journey for some people. But everybody should get to that place on their own, such that, again, back to that deathbed, you look back and you're proud of the life that you've lived. Everybody has a different thing in their heart. Okay. Adenomyosis due for surrogacy? It can be. Absolutely. I had a patient that had endometriosis and adenomyosis, and she's had 3 IVF cycles with all of the transfers, and we tried it all. You look through the chart and it's like massive, and she has decided she's going to use surrogacy. Again, you have to get there when you're ready. Same thing as I get the low reserve patients that they're in their late 40s and they're not ready to jump into donor eggs. You have to get there and feel that you've tried and that you're ready to close that chapter, and it's okay, and you can move on to the next thing. Have you heard of the female endopac messing with the thyroid? It can. Believe it or not, those supplements are extremely powerful, and they're going to stir up the endocrine system. In the majority of cases, it's actually a good thing. It might mess up your cycle a little bit. It might mess up the values of the thyroid, especially if you have been on medication. Suddenly you might need less And then, but that usually will level out. Okay, I have used that myself. My spouse is gender fluid. Again, you know, we have all sorts of people going through this journey, and I've had, um, people that have changed genders and they still want to use their seeds, okay, whether they were female and they became male and they're going to use their eggs, and I have males that are going to do the sex change and they're going to use their sperm. So we help them all. We help them all. Will the Atlanta office be offering IVF in the future? It is in the plans. So for those of you that are not fully familiar with CNY, the main office is in Syracuse, and there's IVF in Syracuse. There's surgeries in Syracuse as well. Albany is the other center with IVF. It's a little smaller than the Syracuse office, but it's closer to New York City. And then there's Buffalo and Rochester. Rochester is a monitoring facility. Buffalo should be getting IVF anytime soon. And they are working on opening Colorado. And then Atlanta is also working on getting an IVF lab probably next year. Okay, where there's all these steps that need to happen, and we're diligently working towards that. Is male morphology of 7% plus PCOS successful for IVF? Yes, it should be successful. PCOS is, I consider it to be an easier challenge, honestly. Sometimes we have to tweak, because with PCOS, and I've discussed this a few videos ago, you have the very high responders, but you have the very resistance. We just have to kind of check out what are you. Okay. I'm trying to be fair. Okay, so after 2 days of 300 of Gonal-F and 300 of Menopur, I only have 3 small follicles. My usual antra-follicle count is 6 to 7. Should I cancel this cycle? Why don't you lower the medication that you're on? I seldom will give those high doses because they seem not to work so good. So why don't you go down to like 200 of Gonal and 75 of Menopur, and then try to stimulate a little longer. I would not necessarily cancel. I would try to spice it up, even do a PRP, an ovarian PRP, whether it's intra-ovarian or high volume, could be the that extra icing on the cake and push those ovaries to work a little better. If nothing happens after a PRP and decrease in the medication, I would say in the next 5-6 days, then I would cancel, prime, and start again with a lower dose or even a luteal phase start. Do you allow more than 1 embryo to be transferred at once? Yes, we do not recommend. I've discussed this a few videos ago. The rules of the game, okay? I'm going to tell you the rules of the game, and I'm going to share my opinion. The rules of the game: 35 and lower, 1 embryo at a time. 35 and over, you can go up to 2. If there's PG tested embryos, no matter what your age is, 1 is recommended, because more is not better. It actually could increase chances of miscarriage, complications if you get pregnant with twins, including later miscarriage, like losing your babies at 5 months of pregnancy. I've seen that. Preeclampsia, diabetes, even preterm labor on, like you don't want to have 2 babies in the ICU for 2 months and then probably have complications from prematurity. This is not a spontaneous twin pregnancy. It is a forced twin pregnancy, which is very, very different. The other issue is that your embryos are like golden tokens. They're really, really valuable. And if you start, you know, like you're in Dave and Buster's and you're like flipping them, you're going to lose, you're going to be back to square one very quickly. So take all of those things into consideration. If after all of your thinking you still want to put 2 in, most doctors will allow you to do that. It will be ultimately your decision. I need good recipes for ketos. Eggs are getting old. Yes, there are plenty of recipes. Eggs are easy, but they can get, you know, boring after a while. I get you. But, you know, you can spice it up. There's even like keto, paleo bread. I had the most amazing banana keto bread. It was more like a paleo, but still grain-free with coconut flour, the bananas, that's not keto, but and almond flour, and it was like to die for. And then you can slice it up, and then you have bread, and then you can have a sandwich. And then, you know, so it's a matter of getting a little creative. Does hidradenitis suppurativa affect fertility? No, it does not affect fertility. It's a skin condition. I have worked with that condition many times, and you can, if you want me to help you with that particular issue, you can definitely message me privately and give me your information, and we can talk about what to do with it. Metformin long term, yep, I mean, it's not going to hurt. There's plenty of people in this world on metformin long term. There's very few side effects, okay? Thoughts on metformin for transfer if no PCS or insulin resistance? Not so keen. Not so keen on it. You know, I mean, I like thinking outside the box. It would not be my first, third, fourth, fifth, sixth option. If after trying everything else and you want to throw it on board, then I'm not going to fault you for it, but it will not be my first thought for sure. Recommendations for prolactinoma patients: tumor almost gone, bromocriptine for 8 years, prolactin normal. No problem, Danielle. We have plenty of people with prolactinomas, not active, but actually still on MRI showing presence. So your case is a little bigger than this forum, but yes, we can definitely help you with that. Keto, I mean, keto is such a good diet for the endocrine system. So keto-ish, stay on that paleo-keto side of the spectrum. Gland therapy works really, really good for people with prolactinoma. So things to discuss. I had a PGS tested embryo, failed implantation, all labs were good. That is kind of complicated because they're talking that, you know, the biopsy could damage the embryo. It's kind of a, you know, damn if you do, damn if you don't. I would look at what you have and move forward. I mean, what can be done differently? I mean, did you check on the lining? Is there any chronic inflammation? Do we need to do a scrape PRP, antibiotics? Do we need to put you on a different regimen for your transfer? So we would have to look at your entire chart and see what can be done differently. For my thoughts on PGS testing is, unless you have a very good reason, you should let the embryos be. So what are good reasons? Known genetic familiar, you know, genetic disorders in the families, knowing that you're carrying something that could be lethal and you don't want to pass it on to your children, absolutely. You want to do sex selection to balance your family, go ahead. But for everybody else, I would stay away from it and just go through the grading that the embryology does. That's what I would do, and I am a 40 plus girl, and I would not test my embryos. Oh, great, awesome. I love happy endings or happy stories. So we have a positive beta. Amen. 45 with my own eggs. I'm telling you, I love what I do. Let's, let's keep pushing that envelope. All right. Well, very good. We came to the end of this story for tonight. I hope it was useful and that somebody out there will benefit from our discussion. May you all be blessed. I will see you next Tuesday at 9. I'm doing every Tuesday at 9 in English, and I do Spanish on Thursday at 9 p.m. as well. So Tuesdays English 9, Spanish at Thursday at 9. Again, I'm Dr. Verdiales from CNY Fertility Atlanta and Rosara Health, the Wellness Center. May you all be blessed and have a great rest of your week. Bye-bye.